Hi, so we'll be talking about the biomechanical examination of the sacroiliac joint. From this point on, understand that the diagnosis of SI joint biomechanical dysfunction has been made. It was made from the initial diagnostic exam. So the patient came in and complained of all the stuff in the essential illness script, and you ended up with, the objective exam gave the appropriate findings. You've done bias correction, you've completed the exam if that's what you want to do, and that diagnosis has been made. The only way the biomechanical examination will contradict that diagnosis is if the examination proves to be negative. Now, in that case, either the diagnosis is wrong or your examination was bad. One of the two, it can't be anything else really. So that diagnosis is made. There's no more conversation about that. There's no querying whether it's been made or not. It's been made, and we move from that point on. Having said all that, we'll just review the trip to making this diagnosis. It's based on the EIS, the essential illness script, or if you're doing pattern recognition or any other form of hypothetic inference, whatever it is you're using, which made the diagnosis. The EIS for this is almost always unilateral pain that's moderate, with moderate referral. It's an episodic thing, non-obligate extension impairment. This is mostly about extension. You have a positive subjective Fordham area, and the objective Fordham test is positive as well. Extension and side flexion range of motion are the most affected. Differential diagnosis, lumbar segmental dysfunction, and this is always an issue because often they've got both lumbar pain and sacroiliac pain. But even if they haven't, the lumbar spine can refer to the buttock. So this is always a differential diagnosis for SIJ biomechanical dysfunction. Disc herniation, contained and uncontained, can also be a differential diagnosis for an outlier of SI joint where there is intense pain. If you have intense pain, we'll look at this in a second, all the movements are going to be affected, and there's going to be a lot of referral. So it can look very much like a disc herniation. Difference being that Fordham's is negative, unless of course you've got both going on. But what will be really positive for the disc herniation is the lumbar PA. Another differential is systemic sacroiliitis. Again, this would be for an outlier of biomechanical dysfunction with severe pain, and also intra-articular fractures, which is going to lead you to a different diagnosis anyway. There's going to be trauma and immediate onset of severe pain. So you're not really going to get these two mixed up. The main outliers of SIJ dysfunction is, as always, is first episode, flexion impairment rather than extension impairment, severe pain with increased referral. That is often on the first episode. But remember that the SIJ is a big joint, so there's a lot of nociceptors present, so you can get a lot of pain from it. More often, this is more painful. When it is painful, it's more painful than, say, a lumbar dysfunction. And if it's really severe, you're going to get flexion and extension impairments. So this is EIS, differential diagnosis, and the outliers. So all of that should lead you with this diagnosis. Now, a word about when both are going to be diagnosed or you're confused between lumbar and dysfunction. The two differential tests are Fordham's test, being positive for SIJ, and also PAs being positive or negative, of course, for lumbar spine dysfunction. With the Fordham's test, if they've got both problems going on, they will give you a positive Fordham's test, but they're likely to turn around and say, I've really got two pains, two areas of pain, one there and one in the lumbar spine. That's usually what happens. Even if it doesn't, PAs and Fordham's test between them will give you an idea of what you're doing. And then, of course, the biomechanical exam will give you the diagnosis on both of them. To expand on that a little more, you're looking at differentiating between the lumbar spine and the SIJ as the source of the patient's pain. Now understand that you can have an asymptomatic sacroiliac joint that is going to screw up the lumbar spine. And that's more often the way it goes rather than the other way around. You can do it, it's more often that way than the other way. And certainly they can coexist. Pain from both or pain from one, it can all coexist. So just to get this clear, you've got Fordin's test and lumbar PAs. If Fordin's test is positive alone, then you have an SI joint dysfunction, biomechanical exam at the end of that. If Fordin's test is negative, but PAs are positive, you have a lumbar dysfunction, and again, biomechanical will tell you that. If they're both positive, then, if they're both negative, then you need to do a complete biomechanical examination on both and really try to reproduce this pain. So pain reproduction tests for the SI may well be quadrant testing of the hip. You can put enough stress through there. Fordin's test objective will also give you an idea that Fordin's is in trouble. So if both tests are negative, you've only got a couple of options here. Fordin's is insensitive, lumbar PAs are insensitive, which is going to be extremely rare, or neither of them in trouble. But then you may be looking at a visceral problem or something equally weird. Okay. So the meat of the problem. Now we've made the diagnosis of SIJ biomechanical dysfunction. There's a couple of ways we can enter this. One is through position tests. This is the worst way, in my opinion. I believe they're completely useless and counterproductive as well. And the reason being that every adult has an asymmetrical pelvis. You see the same pattern pretty much every time. The innominate on the right is more anterior than the innominate on the left. That is, it's more extended than the one on the left. The sacrum is rotated to the left. And this is it. That's almost a universal pattern for this thing. Doesn't matter whether you're left-handed, right-handed, that's what you see. Doesn't matter if you're in the northern hemisphere or the southern hemisphere, this is what you see. So given that asymmetry is there, let's say you're position testing and you find that the right innominate is more anterior than the left. Now the question is that anterior position too anterior, just anterior enough, or not anterior enough? And you've got no metric to measure that with. You can't compare it to the other side and so on. So this is misleading. Position testing is misleading. The problem with it is, it was the osteopaths who came up with this method, and then you do muscle energy techniques, which is neurophysiological, you're relaxing muscle tone, and of course you change the position, muscle tone changes, the position changes, and there you've made a difference. So it's a really poor way of doing it, and I really would advocate that at all. The other entry point is kinetic tests, where you actually stick your digits on, say, the PSIS and S2, and you have them bend forwards, bend backwards, sideways, lift their leg up, and so on. And you have to do weight bearing and non-weight bearing tests, and have to interpret whether or not that which tests are positive, which tests are negative, give you the diagnosis. So if you've got a hypomobility found, so that your thumb weren't moving on one side compared to the other side as much, then if you have that hypomobility, then is it present in weight bearing and non-weight bearing, or only in one or the other? So if it's present in both weight bearing and non-weight bearing, understand that when you bend forwards, there's a lot more force going through the SI joint than if you simply bend your knee up in front of you, giving you the same movement of the innominate, flexion, basically extension. There's a lot more force with it. So if you're getting the test positive in non-weight bearing, for example, but negative in weight bearing, it means it's almost certainly being held by a muscle, and your body weight is enough to shift it forwards. If it's only positive, if it's positive in weight bearing and non-weight bearing, you probably have a stable hypomobility, probably a subluxation. I hope so, because that's what you want to treat. But it's a stable hypomobility, but they're in non-weight bearing and weight bearing. If it's only present in weight bearing and not present in non-weight bearing, you have an unstable subluxation. So when you put weight through the joint, it subluxes. When you take weight off of the joint now, as in bending the knee up, for example, it relapses again. So now you see normal movement. So this system works. It's just cumbersome and it's really unnecessary. You can go straight to passive mobility tests. And the ones you're going to do is flexion extension of the innomina. You can reproduce the same movement by doing flexion extension of the sacrum by pushing on the upper corner of the sacrum and the lower corner of the sacrum, flex it and extend this respectively. You can look at medial and lateral rotation here, and you can look at supracaudal, and I'm going to use inversion quotation marks here, glides. You can't glide this joint. The contours, primary, secondary, and tertiary contours all say that you can't glide this joint. The most you can do is apply shear force and see what the end feel is when you do this. So you have to do P-PIVMs. There are no PAVMs for this, or PAMs for this. So there's no interpretation with this. The end feel is definitive, and it's much easier to do. You get straight into it, you're over and done with, and it's actually quicker than doing kinetic tests. So it's almost like you're doing a screening test that you then have to interpret, which takes longer than the definitive test. It makes no real sense. I wouldn't do it. Now, there is a condition called, the osteopath called it a sacral torsion, and I touched on this earlier, and this is where it's based on position testing. So you palpate the upper and lower corner of the sacrum, and you find, say, the right sacrum is posterior compared to the left side of the sacrum at the top, and at the bottom, the left ILA, the inferior lateral angle of the sacrum, is posterior compared to the right. So the only way you can really do this is if it twists around. So it twists in the middle. Now, it is possible, as I said, if you actually have a torsion across S1-2, because that disc can be very, very well developed and just encased in some cortical bone. So it's arguable that you can get that torsion in there. But there is no position test. There's no kinetic test that will show that. There's no passive mobility test that will show that. Only the position test will. So my guess is it really doesn't exist as an entity. And certainly the standard manipulations on this work. The manipulation for a sacral torsion is you have the patient basically lay on the stomach, you push down the ILA and you extend them at the same time. And it's a very airy-fairy condition. That's what I would leave until the last resort. Your standard manipulations work really quite well with this. Okay, nice short presentation. Not really, the SIJ is not terribly complicated. If you look at the osteopath's interpretation of age, it is complicated. But if you think about the sacrum as L6 and the innomina as L7, then basically you can think about it in exactly the same way. If I want to test L5 and L6 for the PAVM and the PIVM, actually, I'll push on the posterior transverse process. You can do exactly the same thing here. You either push on the upper corner of the sacrum to get flexion, or the opposite lower corner of the sacrum to get extension and making it fold back. So I think the analogy is pretty good here. L6, L7. Otherwise, there's nothing really complicated about this.